So there's the question. Type the answer for me in the chat. First response is on the money. So I think we used to think of it in terms of kind of, those very clinical features, but a sort of systemic inflammatory response plus infection as a cause of that. And then the world's moved on. So we've, a lot of these things come through consensus conference. And fundamentally, so we currently work on what's called a Sepsis 3 out of that conference. And it's very much about a life-threatening organ dysfunction, which is caused by a dysregulated host response. So I found that a bit odd when I first saw that written out of that conference. But it's the infection is there, but actually it's the fact that your body has mounted such a massive response to it, is what truly causes sepsis. I mean, where there's a toxin, I suppose that's being stretched a little bit because the toxin itself is probably directly causing some of the vasodilation as well. But anyway, that is the definition we use. I'll just touch on a couple of bits that adults use and we don't tend to use ourselves. So there's something called the SOFA score, which if you've not heard of, it's just good to know it's there. I'll show you the scoring system for that in a second. But fundamentally, at least in adults, and true really of pediatrics as well, just a couple of these markers being abnormal puts you in a really high risk category for mortality. So if you look at that box below, just being hypotensive with a raised lactate puts you into a really high risk of death group fundamentally. The SOFA scoring system looks at lots of kind of metrics and numbers around physiology, but as you can see from that lower box, which can easily categorize you as being high risk, there's something called the Q SOFA score, which you could glance at anyone in ED and say, well, have they got a raised rest rate? Are they slightly obtunded? And is their blood pressure low? And actually, just those simple things push you into that high risk category. And certainly in our ED at George's, I know on the adult side, they use a lot of these scores and assessments to risk stratify people in terms of what the clinical response should be for any given patient. So what has influenced our decisions? I mean that in the broadest term, but in terms of how we're going to respond to our patient. So I'm just going to sort of take you through a very short sort of potted history of some of the things that underpin what we do clinically for our patient. So hopefully everyone has heard of the Sepsis 6. There's a chap called Ron Daniels from the Midlands, and if he was an adult intensivist, and I think the story goes, he was sort of, worried, frustrated, concerned by the number of septic patients who would come up to ITU, being in a high risk of death category. And actually he could see that some of the real basic things just either hadn't been done or hadn't been done quickly enough. And he sort of looked at what those things were, tried to simplify it, and fundamentally came up with these pretty simple 6 things, which if you get them right, can put the patient, on a path perhaps to have the best chance of getting better. So I think they should be familiar to everyone, but there they are, and that's the history of how they came about. I've seen some places have little lanyard cards and that sort of thing for these. There's a risk you end up with a lot of lanyard cards, so not that we're allowed lanyards either at the moment. Another bit of sepsis history. So there was a concept kind of 15 years ago about something called early goal-directed therapy. And fundamentally that came out of a trial in a Detroit urban hospital, so a trial run by a chap called Rivers. And he looked at whether if you kind of brought ITU to ED and did some really targeted interventions with an algorithm and targets, so hence early goal-directed therapy, he looked at whether you could improve outcomes in sepsis. And actually his trial showed a massive improvement. And I forget the exact numbers, but it was in the magnitude of sort of tens of percent, 20 or 30% survival increase. So that suddenly put this early goal-directed therapy algorithm, if you like, firmly on the map. Could we do better by Ron Daniels had looked at the basic things, but actually perhaps doing a few more sort of ITU type things, looking at central venous pressure, blood pressure, having an algorithm for vasopressors or inotropes. central venous sats, which we'll come back to if that's not something you're familiar with, urine output, etc., those sorts of things. So achievable in ED, but actually does require a central line to go in ED to get going on this protocol. So big benefits shown by the Detroit trial, but actually 3 further trials then completely failed to show any benefit. Reason I mention this is it's a bit of the history of sepsis management, but also if you're someone that likes research, so Process, Arise, and Promise are a really good trio of trials to look at. So they were designed together at the beginning so that when they were all complete, all of their data could be put together. So, USA, Australasian, and UK data. So independently, the trials showed no benefit. They've been designed so that then you could easily, without complication, have one big data set that worked. So they're a really nice example of collaborative working. So if that sort of thing interests you, then it's worth knowing about those 3 and going to have a look at them. Catherine Maitland paper, mortality after fluid boluses. We're not going to talk about that now, but again, it now fits into the history of sepsis and why we do what we do. And this suggested that fluid boluses could actually be deleterious for children with sepsis. And, there were lots of, not necessarily criticisms, but differences to, say, a UK population brought out and whether it was truly applicable. But I think it is fair to say that it's part of the reason that we moved, not deliberately as such, but we moved from 20 kilo boluses to 10 mils per kilo to an extent. So again, if you're not super familiar with that paper, it's worth looking at. And then in London, led by David Imwald, who was at St Mary's, a pilot study was started called the FISH trial, Fluids in Shock. And actually one of the questions that I wanted to look at is, should we give 10 or 20 mils per kilo fluid in severe septic shock? And actually what the pilot showed was that a full trial could not be achieved, and really it was for a couple of reasons. One actually is severe sepsis is now, the incidence of it is way lower than it was in, say, the late 80s or 90s, again for various reasons we won't discuss here. But also, and perhaps more importantly, the world had already moved on and people were already giving 10 mils per kilo repeatedly rather than 20s at that point. So the opportunity to do the full study was not there. So that's an example of a pilot study actually showing that the question can't really be addressed in a full study. Right. Let's imagine you're in ED and you were looking after that patient and you did what you did. You assessed them, you gave fluids, you gave for that patient dopamine, but now it might be a different drug, and then noradrenaline was started. Which guideline is it actually that's telling us to do those things? If you were criticised afterwards, what would you say? Which guideline were you following? And I don't mean which, you'll have a hospital sepsis guideline, but actually where was the primary publication of the algorithm that we follow? So UK Sepsis Trust tools we'll have a look at, but they're not, again, that isn't actually the guideline. Peer network I'm actually not super familiar with. Maybe at the end you could tell us about that. So APLS and STRS, again, they're taking information from a different guideline. So it's the International Surviving Sepsis Group or Surviving Sepsis Campaign. And this is a guideline published by a US group, so the Society of Critical Care Medicine, SCCM, and published in Critical Care Medicine. And actually, this isn't the latest version that I'm showing you, but this may be familiar to some of you. You might have seen this algorithm sort of copy and pasted, but that's where it comes from. It gives a time chart down the side. It makes the point that actually you have to get on treating very quickly. Actually, this guideline suggests you should be proving fluid refractory shock in 15 minutes. So, giving up to that 40 or 60 mils per kilo within 15 minutes, that is difficult to do. You're going to need probably 2 people dedicated to flushing fluids in to achieve that in 15 minutes. And of course, where does your 0 minutes start, right? Have you missed the patient for a while? Did they not get brought to your attention? So, if you thought of auditing your practice on this, achieving that is really difficult. But let's look at what it shows. So it says, and it may now say 10, we'd have to go and look at the latest one actually, but it says give fluid, And if your shock isn't reversed, meaning fundamentally actually your lactate isn't falling into the normal range, but all your other parameters looking better as well, then it says very early now, and this is one of the recent-ish changes, you should start a drug to support blood pressure. And we'll come on to a little bit more about that in a minute, but inotropes or vasopressors. And then the bit to remember is if that still doesn't work and you're potentially on 2 drugs, then actually we should give steroids to cover for relative steroid insufficiency. And then it talks about some of the ITU monitoring things, central venous pressure and central venous SATs, which I'll talk about briefly shortly. And then the old version at least divided you up into cold shock or warm shock. And right down at the bottom, I suppose it's worth knowing it's on there is, don't absolutely exclude ECMO as a possible thing. So it is something we should probably discuss with the ECMO teams, and it's for them to sort of make a outcome risk-based decision about whether they feel ECMO has any role for your specific child. But it is there on the guideline, and you should know that. So, these are the papers. This is what I was trying to get to. Very international group. There's definitely a few people from George's on there, but you may recognise other people from the big centres around the UK who've joined in this group. Someone mentioned UK Sepsis Trust. I'm just going to show you some of the sort of pictorial, graphical patient flow, clinical aid type things. So Surviving Sepsis has this kind of guideline. These are all freely available. You can decide if they're useful in your clinical environment or not. And I thought I had the sepsis tool. Oh, maybe I've got rid of them. But so someone mentioned the UK Sepsis Trust, and they also on their websites have various sort of tools and flowcharts and posters and things. And if you get in touch with them, you can use them, maybe adapt them very slightly, but you can get ones that are branded up for your own hospital as well. So do have a look at the UK Sepsis Trust guidelines. And then someone mentioned NICE, absolutely NICE, and all of our other protocols, but actually they're fundamentally founded on that original SCCM guideline that I showed you. But again, you should be familiar with the NICE guidance and kind of how it guides you. We'll move on now, and we'll just think about inotropes and vasoconstrictors probably for about 10 minutes. So NICE to an extent, and there is a NICE sepsis guideline, but it draws on the original guideline. So being honest, I used to feel, starting inotropes or vasopressors, it's a kind of big, scary decision. And it sort of is. It's you recognizing that your patient's very sick, they've met a certain threshold. But on the flip side, as I've perhaps got a bit more comfortable with these things, and it's a bit more an everyday thing for me in the role that I do, actually it really isn't a big decision. If a patient looks like probably they're going to need these drugs, it's actually much better to make them up, have them ready early, and potentially even start them rather than wait for them to really get worse and show you that they desperately need them. So, if clearly something's going the wrong way, definitely bring in your team and your sort of advisors and speak to other people if you need to. But try not to have this kind of fear of adrenaline and noradrenaline. Ultimately, it may help stabilize your patient. And on the flip side, if you start them and they're not needed, it'd be very obvious they have an absolutely stonking blood pressure. All their other numbers will be getting better, and actually you can wean them. There's such short-acting drugs that if you're on too much or don't need it at all, you can wean off it. And we do that in PICU sometimes. An immunosuppressed child might come in with a line infection. We start it, either they turn around with antibiotics, or when their line's out, they get better very quickly. And we just wean it and stop it. So try not to let that decision around starting inotropes be too much of a big one for you. And just remember, those guidelines actually suggest you should be thinking about starting them at about 15 minutes into your sepsis management. So our choice of inotropes is actually very narrow. So fundamentally, if you're in ED or anywhere else, you really these days only have a choice between adrenaline and noradrenaline. And I think that's pretty helpful to think of it that way. So number one, decide whether you need to start something or not. Number two, which one are you going to give? And that's sort of the end of it, really. And if you start one and the patient's still looking awful and you end up on a big dose, then you start the other one. And then, as we said, you add in steroids then after that if things are still looking bad. And again, I would have a very low threshold for steroids. If I end up on 2 drugs for a child and things aren't looking absolutely rosy, I will just give the steroids, because being on 2 of these drugs is a pretty bad sign in itself anyway. And you know that steroids are going to take a time to work if they're going to help you. But obviously make sure you've given antibiotics and done blood cultures and that sort of thing ideally first. Dopamine we'll touch on, but actually really almost no one uses it now. SGS used it for quite a long time, but stopped kind of a couple of years ago, particularly when everywhere started to become more comfortable with peripheral adrenaline for the children without central lines or IOs or central access. So again, just make sure you've had a look on your local retrieval service websites for the peripheral adrenaline protocol. And less commonly, but not absolutely ruled out, is peripheral noradrenaline. But I think probably people are still just a little less comfortable with that. Who would like to offer me then a little bit of a thought process or opinion or algorithm about how you're going to choose between adrenaline and noradrenaline for any particular patient? Yeah, so again, this idea of warm shock and cold shock, and actually I think it kind of works for making that decision. If a child's got sepsis and cardiac dysfunction and that makes them shut down and cold and poorly perfused, that sort of theoretically old definition of cold shock, you're probably not going to have someone there that can do an echo. The cardiac dysfunction might be a little bit on the subtle side and hard to sort of diagnose unless you're a bit of an expert doing echo. So really, what are you left with? You're left with just diagnosing a child in shock, and then they look like they don't have great blood flow around their body. So in that circumstance, adrenaline makes sense. It's going to make the heart pump harder, and hopefully it will kind of put up your cardiac output, get the blood flowing better, and as a consequence, increase your blood pressure. On the flip side, if you're in warm shock, so you could still have a bit of cardiac dysfunction, but probably your heart's pumping well. In fact, it may be pumping above its normal cardiac output. But if you've got a toxin and your blood vessels are dilated, so that distributive shock, fundamentally you just don't have enough volume for the amount of dilation. So you can do 2 things. You can give fluid, which you'll already have done, and then you can give something to reverse the abnormality, which is the vasodilation. So you'll use a vasoconstrictor to squeeze those blood vessels back, but you're squeezing them back towards normal rather than wanting to make them to go smaller than normal. And that will put your blood pressure back up. And remembering that your heart actually needs your diastolic pressure for its own perfusion through the coronary arteries. And then you can see, things improve because you'll perfuse everything better with a better blood pressure. Because you've squeezed the blood vessels back to where they should be. There's always a bit of a kind of academic debate between blood flow, which is actually what we want, versus blood pressure, but they're interdependent, and of course the pressure is important to drive the flow down the gradient from arteries to veins. So both important. We won't perhaps get into that heavily technical debate just for the moment. So honestly, that is how I really think about whether to start adrenaline or noradrenaline. And again, if one isn't working and you're up to kind of 0.5 micrograms per kilogram per minute, or getting up towards that, and the kid's not looking like they're going to stabilize or have a good blood pressure, then in reality, you're going to start the other one as well. And then you probably just have a decision to make. Are you going to lean more towards adrenaline or more towards noradrenaline? You still probably want that balance to be a bit more weighted towards the direction of what you think is the problem. Sometimes cold shock, you give them fluids, a bit of adrenaline, and then a bit of time, or you support them by them being intubated as well. And actually the cold shocks can start to look a bit more like the warm shocks once you've got the heart beating and pumping better. and then you might want to add a bit of NORAD on if they sort of convert from that cold shock to warm shock through your treatment. The other thing to remember is if you're looking after neonates or babies, they have a really fixed stroke volume, and actually their cardiac output goes up and down entirely dependent on their heart rate. So you never want to have a bradycardic neonate where you've got blood flow issues. So that's where in the old days dopamine or otherwise adrenaline, actually one of its primary functions in a neonate might just be to be speeding the heart up a little bit, which will lead to greater output. We'll look at that again in a bit more detail. Just some words. I think most of us just use the word inotropes most of the time, and I think we all know what we're talking about. But actually, to be truly correct, inotrope just means you're making the heart beat harder with more effort, more force. And largely that's what adrenaline is doing. Chronotropy is making it beat faster, so again, adrenaline would do that. Dopamine particularly would do that. If you use noradrenaline, your blood pressure goes up. You can actually get a baroreceptor response, and your heart rate can go down with noradrenaline. Although again, usually that's only if you're sort of driving the blood pressure up a little bit higher than it should be. But if a lion bolus is noradrenaline, you can see a bradycardia, so it is a real thing. Vasoconstrictors, so squeezing in those arteries and arterioles, and then vasodilators, which obviously you don't particularly want in sepsis. So there's just a bit of clarity around the kind of words and things. This really we've sort of talked about at a physiological level. So fundamentally, we're going to use these types of drugs if you're shocked. So that might be cardiogenic shock, where the heart's not pumping well, distributive shock, where your vessels are dilated, as we said, and then some special circumstances. So, for example, if you've got spinal cord injury, you can lose your sympathetic output below the injury. So spinal shock is, again, it's just like your body having effectively no sympathetic system. So that's where noradrenaline might be perfect, again, just to try and squeeze those vessels back up. Neuroprotection, so good blood pressure is one of the key parts of that. So actually you might have an okay blood pressure, not a terrible blood pressure, but just a little bit of noradrenaline to lift up the blood pressure to hit your neuroprotective targets might be the thing there. So obviously these are non-sepsis examples, but just worth a brief thought about. This slide I think I stole off my colleague Jonathan Round, but the sort of cold shock, warm shock, essentially it sort of summarizes this. So do you have a pump problem, or do you have a blood vessel problem? And a bit of filling may help for both of those, but ultimately if it doesn't, and if you've got one, obviously you address that, but actually if you've potentially got both, it makes a lot of sense, to fill the pump, and then to make sure the pump's working well, and then finally to make sure that your vasculature is good. So fluids, potentially adrenaline if you're cold shock or cardiac dysfunction, and then ultimately some noradrenaline if you think you've got a vascular tone problem. Anyone who works in adults or has looked at the adult literature, adrenaline is really strongly associated with a bad outcome. And it is an association rather than a proven causation, but it's pretty rare to see adults start adrenaline first. Nearly always it would be noradrenaline. But again, you just have to think, what's the problem? Is it maybe children have that bit more of cardiac dysfunction when they're sepsis, or is it that in adults that's not recognised? Certainly if you've got cardiac dysfunction and then you just use an afterload increaser, noradrenaline, vasoconstriction, actually that's going to make the heart work harder. So failing heart having to work harder against an increased blood pressure could be a problem. But I make that point just because anyone coming from the adult side may be surprised when you ask for adrenaline. So last section really is just for us to have a little think about physiology and what we can measure. I'll just trot through some of the sort of pharmacological bits about adrenaline and noradrenaline. and then we'll come to a close and wrap up. So mean arterial pressure, the sort of equation that ties all this together is your cardiac output times by your stroke, by your systemic vascular resistance is what affects your blood pressure. So if cardiac output goes up or down, your blood pressure can do the same, and also if your vascular resistance goes up or down, the same. So this is why adrenaline and fluids might be your friend here, whereas fluids and noradrenaline might be your friend over on that side of the equation. So it's kind of, it's about understanding what it is that's gone wrong in your patient. And remembering cardiac output is stroke volume times heart rate. And again, that heart rate is really, really important in neonates because they can't change their stroke volume in the way that we might, using the sort of Frank-Starling law, and more preload leads to more stretch, more contractility, and more cardiac output. Some of you may not have sort of thought too much about the concept of central venous saturation. So I talk about it just really in outline because, it featured in the early goal-directed therapy, and actually it does feature on the SECM guidelines as well. So it's worth knowing a little bit about what it is. So when your heart pumps blood out, obviously the sats should be at 100%. Blood goes around the body and then it comes back to the right atrium, and it will have had some of that oxygen taken out, certainly not all of it. And when all of your bloods come back and it's mixed, and if it was perfectly mixed, for any of us sat here right now, this is the sort of range that you might expect it to be, probably up a little bit nearer for a healthy person at rest. And you can imagine lots of things will lead to your body extracting more oxygen out. Increased demand is one. And the other would be actually if you don't have enough blood flow. So, if you think the definition of shock is inadequate delivery of oxygen to the tissues, a sort of going back a step on that is perhaps not enough blood flow or cardiac output. So as sepsis, septic shock, or poor cardiac output develops, you can imagine your body's going to start extracting more oxygen per unit of blood out of your bloodstream. So effectively what you would see if you had a central line going perfectly into the mixed pool of right atrial blood is your central venous oxygen saturations will start to fall. So a falling central venous sats is a bad sign, and a rising one, which is heading back towards the normal range, is a good sign. I'd say we don't use this number a huge amount, but it's worth knowing about. And actually, the place you will see this discussed a lot is the cardiac surgical PICUs, where actually, as long as you understand all about your patient, this can be some marker about how well your child's cardiac output is going. Reasonably accessible marker, which you can just get from a simple blood gas, as long as you're getting blood from close to the right atrium. If you've got a short line in your neck, or you've got a short line in your femoral vein, actually all you have is your leg venous saturations or your head venous saturations. So not necessarily quite as extrapolatable to your whole body circulatory setup. So we said these are the two drugs. You'll remember that we have predominantly alpha and beta receptors in terms of adrenaline. We're not going to think too much about dopamine today, although I've left some slides on there in case anyone at any point wants to sort of go back and read a little bit about dopamine. It's certainly often still used in neonatal services. And maybe still some odd cardiac center uses as well, but for general peds and sepsis, we'll skip over it. So adrenaline, you'll remember, actually can trigger alpha and beta. So it's obviously an agonist because it is adrenaline. Think about your counter example. So, beta blockers, for example, would be effectively blocking the effect of adrenalines. And then a beta 2 specific, we'd use asthma salbutamol. So that just reminds you that your beta 2 receptors are going to be more in sort of airway and that type of thing. And beta 1 is very much heart and heart rate and increasing that rate and power of your heart. So cardiac output, fundamentally. Downsides you can predict. So lactate can rise just because actually you funnel a lot of glucose down your glycolytic pathway, so you get lactate. If you remember that metabolic pathway at the bottom, you get to pyruvate. If there's lots of oxygen around, that pyruvate gets passed through and enters the Krebs cycle. But if you're short of oxygen, so septic shock, you get sideways anaerobic shunting into lactate, and that's why lactate goes up in septic shock. But also remember, it's a biochemical pathway. If you send a lot of sugar down from the top, you'll just overwhelm the lower down bits, so you can actually get a raised lactate just because you're putting too much in at the top. A good example of that is, again, it's salbutamol doing that. So that can be, it isn't necessarily, but it can be one of the reasons lactate goes up in an asthmatic where you're giving them lots of salbutamol. Predictable tachycardia, and again, like salbutamol, you can get low potassium and high blood sugar, sort of effectively a stress response that you're giving the patient by injecting them with adrenaline. Noradrenaline, so much more of an alpha receptor action, which is your vasculature and tone and that vasoconstriction we've talked about. And again, just remember, as you put blood pressure up, that's more work for your heart. Because the afterload has gone up, and you can just get that little dip of heart rate as a baroreceptor response. Side effects are fairly predictable in terms of vascular squeeze. So I told you that our patient ended up with some ischemic limbs. So that is truly one of the side effects. Obviously, hypertension if you're giving it supraphysiologically, or your patient's getting better and you're not weaning it. And then the other bits we have already talked through. Adrenaline's interesting. If you give low dose adrenaline, by which I mean 0.1, 0.2 mics per kilo per minute, up to, at a push, maybe 0.5, it very much behaves like adrenaline. So it behaves in the way that I kind of listed and said. But if you go high, or certainly above 0.5, and actually probably also when you give a bit of a bolus dose in resuscitation, it actually starts to act much more like noradrenaline, and it will hit the alpha receptors. So just keep that in mind. Low dose adrenaline behaves like adrenaline. High dose adrenaline, actually you start to cross over into noradrenaline type effects. So ideally you wouldn't necessarily go over 0.5 of either drug, but our absolute max is, if someone's in deep trouble, it'd be 1 mic per kilo per minute of both. I'll mention a couple of other drugs, but we're not going to focus on them because really they're probably PICU only drugs. Vasopressin's one. So, sort of DDAVP type drug. It's an incredibly powerful vasoconstrictor. So if you're on adrenaline, noradrenaline, and steroids, and the child still looks like they could die from cardiovascular collapse, vasopressin is a drug just occasionally we will get out, and it's effective because it's such a powerful vasoconstrictor. But again, it pushes you towards that situation of limb ischemia, risking digits, risking hands, feet, risking whole limbs. So it's an extremis drug essentially in terms of septic shock. Milrinone, I'm not going to talk about. It's an expert drug to be used under careful advice. It's certainly not a standard drug for septic shock. We might very, very occasionally use it in situations where there's really bad cardiac dysfunction, but it needs to be weighed up incredibly carefully. It helps the heart in terms of the heart muscle relaxing and filling so that you get a good stroke volume when it does eject. But it has a really unwanted side effect in sepsis of vasodilation. So, if heart failure was an absolute standout feature, we might have a think about it, but it's basically quite close to being a drug you really shouldn't use. Much more we'll use it on our unit if we've had a child, say, with a intracranial event, a terrible bleed, and that's led to a sort of sympathetic outflow, catastrophic cardiac impairment, that sort of thing. But I mention it just because people will have heard of milrinone, and there may be some extreme examples where you see it used with with expert specialist advice, but it absolutely is not an ED or a general drug for use. And it's got a very long half-life. So if you give it and realize you wish you hadn't, for example, if you get bad vasodilation and the blood pressure drops even further, you can't really undo it. It can be good with noradrenaline, which kind of counteracts that vasodilation. But again, I mention it really in passing, and it's not a drug to be used lightly, and almost never in sepsis, to be honest. Just want to share a couple of resources. This is a book on the left that I shared that little excerpt from in the beginning. Vignettes, very stereotypical, but maybe it frames our mind while we're thinking about actually how we assess and treat these children. Well, this is a nice read. I'm not sure it's been updated in recent years, but it's a sort of A5, half-inch thick book, and it's a nice sort of trot through paediatric intensive care. The book on the right is much more of a sort of handbook, very facty, very sort of Oxford handbook. But they're not bad if you just want a little book or two to sort of guide you, or if you want to learn a little bit more.